John Welshofer. I'm one of the specialists in physical medicine and rehabilitation here at Carolina Neurosurgery and Spine. I've been here since 2005. The term sciatica basically means pain down a leg, and so it's a generic term, and so patients will come in and they may have that description. Sciatica is usually diagnosed in terms of a history and a physical. Sometimes there's collaborating MRI scans or imaging studies that would help establish that as one of the diagnoses. With sciatica, it can be broken down into different age categories, usually between the ages of 30 and 50. Sciatica would be secondary to disc protrusions or herniations that would compress the sciatic nerve, causing the symptoms down the leg. As we age, we tend to get more problems with arthritis, degeneration, conditions that can cause pinching on the sciatic nerve, such as bone spurs, spinal stenosis. Those things can also cause complaints that would be consistent with sciatica. The first-line approach with someone with sciatica depends on what the history and physical examination would show on the patient. If a patient has complaints of neurologic decline, in other words, they're developing weakness in an extremity, loss of sensation, loss of control, or loss of bowel or bladder, those could be surgical emergencies, so those individuals would get immediate imaging studies. If they don't have that as a complaint, or you notice that on a physical examination, depending on the severity of the sciatica, you may start off with physical therapy, medications, or if someone is more moderate to severe but not in an emergency situation, we sometimes will provide injections to relieve the pressure on the sciatic nerve, and then we would follow that up with physical therapy. I usually tell my patients there's two reasons to consider surgery. The first reason would be some type of evidence of neurologic decline, some type of situation that would represent something dangerous to the patient, a tumor, an infection that could involve neurologic compromise on those individuals. The second group of patients that would be referred for surgical intervention are those individuals that go through a whole plethora of treatments, including therapies, medications, injections, that if those fail to provide the relief that the patient sees, and if they have imaging studies that look like they might be surgical, those individuals then are referred for a surgical evaluation. Chronic or recurrent sciatica, especially individuals that have been through initial treatments, and to me, initial treatments would be standard therapies and medications. A lot depends on what the history and physical examination is. It depends on what the imaging studies show on the patient. Have they had previous surgical intervention? And so it's individual to each patient and what their history and what other attempts have been made in terms of the treatment algorithms that we look at. Lifestyle modifications are very important, especially in the realm of what I do as a physical medicine and rehabilitation physician. We tend to look at things holistically. So lifestyle modifications could include nutritional things. Do they take an anti-inflammatory diet? How much weight do they have? What is their BMI? What type of activities they do on a regular basis? How good are they in terms of their core strength and their overall body health? We are certainly open to individuals going through alternative treatments such as chiropractic care, massage therapy, acupuncture. These do involve lifestyle modifications that can help with the overall conditions that we treat in terms of some of the, whether they're disc problems, degenerative conditions of the spine. From the standpoint of other providers who are treating sciatica, and those other providers can be a wide range of individuals, everything from primary care physicians. We have individuals who will have sciatica who may be seeing their obstetrician gynecologist, and maybe a female who's in the middle of pregnancy. It could be chiropractors, it could be physical therapists. So there's a range of people who come across sciatica in their day-to-day practices. From my standpoint, the important thing to remember is that initial sciatica can be rather severe in terms of the presenting complaints, and it's scary to the patients. And so oftentimes, if you can get them through the tough times to begin with, such that they can take certain medications to calm the symptoms down, and then temporize those symptoms or get them to the point where they can come in and see providers such as us, specialists in terms of spine care like we have at Carolina Neurosurgery, and then we can work them through the algorithms in terms of imaging studies and establish the actual reason for the sciatica. So sciatica is a symptom, it's not a diagnosis, and so a lot of times we would like for them just to try to get them to the point that they can be comfortable enough to get in to see us, and then we take over from there.